Welcome to episode 39 of the Bulletproof Backs podcast. Definitely my most challenging one to bring together all the collaborators, to edit, to overcome language and technology glitches. But I hope you can appreciate at the end of this 20 or so minute recording, exciting things are going on in the back pain world when it comes to neurobiology. Joining me in this episode, I speak to Dr Guy Bewick and Dr Robert Banks, collaborating. They're involved in the University of Aberdeen. But what's really cool is they collaborated with scientists from Academia Sinica in Taiwan, Professor Chih-Cheng Chen, I'm probably getting that wrong, and Dr Jiann-Her Lin and Dr Jiann-Her Lin. All of these brilliant minds together in one room. One of these guys is a muscle spindles expert. One of these is a back pain clinician or back surgeon. One of them is really interested in physiology and muscle spindles and receptor types. To get them to all to speak together, they found each other out while they were conducting their own individual research projects and ended up collaborating and ended up finding a whole new pathophysiology, a whole new receptor mechanism, which, if you understand pain, is super exciting because it offers up for people suffering chronic back pain, particularly those where the medication just does nothing. It helps us now explain why perhaps the pain meds you take are doing nothing, because perhaps your pain is traveling on a whole different pathway to what we have originally thought. So this is a bit of a listening, an exercise in intense listening. I want to wrap it up for you at the get-go and let you know that the languaging in Mandarin and Taiwan, there's a pain that's called tsung pain, and you'll hear the researchers referring to that. If you like, from a Western perspective, we can think about it like the ache or the chronic pain, different to a sharp stabbing injury pain. They have different languaging for their pains, different. Chinese medicine, West and Eastern medicine, culturally we view pain very differently, which is what I think is just so unique and so exciting about this collaboration. If you know anything about the Bulletproof Backs methodology, you will know that pain is an output, not the input. And when sensations are coming into our body, it's how they're classified as threat or safe that really creates an output. And this whole chat is about a new mechanism of that sensation being processed in the body. And if we understand that a whole new pathway, a whole new pathophysiology is involved, a whole new receptor type is involved, then that has pretty huge ramifications. Particularly the hope, I guess, is that pharmacology can now advance a little bit more, create new meds that address this whole new pathway, this whole new receptor type, this whole new glutamate mechanism, which may in the future bring a lot of people who suffer from these fibromyalgia, post-exercise soreness, lingering ache, post-surgery, just general chronic pain may respond a whole lot differently if we understand the mechanisms involved. So settle back, listen in, and do your best. Most of what we recorded has been shelved just because it was just too difficult to understand. But these are the bits. We've condensed the bits that hopefully make some sense to you. If you're not into pain science, you're probably, honestly, not going to get too much out of this apart from what I've already summarized. But I really do appreciate in advance all of these researchers coming together to share their story. And I make head advance and apologies to Dr. Robert Banks, who for some reason, everything we recorded from Robert just did not gel, did not anchor, did not stick in our recording. So whilst you see his beautiful face, you may not hear much of what he had to offer. But let's just trust that whatever we've got is enough for those that are interested in understanding pain mechanisms and this new science. as always, thanks for listening. And yeah, I hope if you're a back pain sufferer, you just take some hope that pain science is evolving and it's cross-cultural, and one day, soon, hopefully, thanks to the work of researchers such as these, we may have better drugs, better mechanisms, better strategies beyond the ones that I'm a big fan of that may literally just help the pain ease. And I hope that brings some hope to our listeners. Talk, first of all, I'm going to go straight to you, Julian, if that's okay. Can you basically summarize these findings in terms of relevance for back pain clients or back pain sufferers that you see every day?
Okay. In Taiwan, especially people speaking, Chinese or Mandarin, they always complain, they have a going of back pain, and they always come to my clinics and say, complain the seng and morning pain in Chinese, okay, in Mandarin, okay. And so so we as a physician, we know that the textbook did not teach us what is seng, but they teach us what is pain. So we treat the seng as a pain, but the efficacy is so poor. You treat the seng with the painkiller. It didn't make sense. Okay, so that's we know that in Taiwan, every doctor knows that very well. So, but we have no other choice, and we don't have any knowledge about this phenomena. And so Dr. Chen, is very, very creatively created this, established this hypothesis that Seng is resulted from acidosis. So now the major finding for now, is we have published a paper last year, and the major finding is we found Seng is quite different from pain, and conducted by different nerve system. For that pain corresponding to or animal model or anything is about regarding as the nociceptive pathway, which is conducted by very small fiber neuron, deep fiber neuron. As for Seng, we have proven that it can be conducted by proprioceptor, which is a very big one, the biggest one neuron. So that is the major finding. That's the major difference we found. The major most important scientific evidence we found. And for clinical part, we found that acidosis, we injected acid saline into the human subject, and they clearly say that those are Seng, not pain. Those are Seng, not pain. So for the clinical, we established the causal effect of acidosis and the Seng, and animal model, we show that the acidosis can be conducted by proprioceptor and resulting in Seng, and it affects chronic pain. And this pathway, neural pathway, is quite different from the receptor, traditional receptor we saw before. Yeah, Dr. Chen,
Thank you.
Have anything to add?
Well, I'm sure Bob will have something to add, or Professor Chen. Who would like to speak next?
Can you hear me now?
We can hear you, Professor Chen. Yes, go.
Yes. Right. I think Dr. Lin, probably Dr. Lin, you can say more about your clinical finding. Yeah, because this what I learned from our interaction. So in your pain clinical, actually, for those patients after the spine surgery, right? So you had done a lot of spine surgery to for patients who have suffered from degenerative spine disease or chronic low back pain. But this symptom is specific prominent after the spine surgery, even 1 year later after the spine surgery, when pain is great significant relief and some maintained and persistent. So
I
think that.
Can
Yes.
someone just explain, because this term, the way you're saying it's TSN, yes, it's basically from what it's not the acute pain, it's the chronic pain.
Both. It can be.
Can you?
So in our language,
Mhm.
in Mandarin or Taiwanese, sun and pain are two different words. So they are two
Perfect.
different words.
Can you explain the difference for us?
Okay, wait a minute.
He's off.
So what's the
This is chart, right? I love it.
This is sun. This is the pain, right? Right. So basically,
Makes total sense now.
yeah.
okay. See again. The upper one
Oh, that helps.
is sun,
That really helps.
and the lower one is pain, right? Right. Okay. Right. So this is in our language is embed in this concept in our language, right? And or maybe we can use some kind of word you can understand in the Western culture. The phenomena after the exercise that in English we call the soreness, right? Right. So soreness is one type of sun, right? So for patients who have the chronic low back pain, 80% of them they have sun. So we do not specifically say this is acute or chronic, but it's the same word, right? It's a symptom, it's a phenotype, right? So we call sun, right? Whatever it is, transient or acute or chronic, right? We call it that, right? And the difference between the soreness or sun after exercise, because this is exertional. Your muscle working, fatigue, and then you have something. So that's you have acute sun or soreness. But for the patient, they have the spine surgery, or they have chronic low back sun or fibromyalgia. It's not exertional. It's the sun is persistent. It's there, but it's not because you do exercise.
Gotcha. Yeah. Not related to movement necessarily. It
Right.
exists without exertion.
Yes. And okay, so I might go back to the how we do the collaboration and how this the concept of sensation evolved, right? So this is originally I'm interested in how tissue acidosis causes pain. So that's the original idea. I have worked in this field for more than 20 years, right? And one of the very caveat issue or very confusing issue is we know there's a key ion channel called acid sensing ion channel 3. Right? This is one of the very key molecules that sense acidosis and produce pain in animal model. But intriguingly, this molecule is predominantly expression in the so-called non-nociceptive neuron, specifically with the proprioceptor. That's the neuron that sense the muscle construction, muscle length, and also the position. That's the Bob and Guy. They are working on this field for I guess more than 30 years. Right. So to understand how this acid switch channel function in the proprioceptor, I need help. I'm not an expert in the proprioceptor. So that's how I reach out to find Guy. Right.
Wow.
Because Guy is this expert in this field.
Wow.
Then we start a collaboration to understand whether this so-called acid sensing ion channel could be a mechanical sensitive channel, because proprioceptor by definition is a mechanical sensitive. The physiological function is to sense mechanical force change, not a tissue acidosis. So that's how we started this collaboration. So we first demonstrate that in 2016 to demonstrate that proprioceptor RC3 does function as a mechanical sensitive channel to sense muscle contraction length change and contribute to the proprioception. So that's the first story. Yeah, that's the first story. Right.
Gotcha.
So that's how we do the collaboration, right? But it doesn't end the story, because the question is still there. If the RC3 in the proprioceptor function as a mechanical sensitive channel, but it still sense acidosis, and why proprioceptor need to sense acidosis? That's the scientific question. So I think this is curiosity driven, right? So this is embedded in my mind for a long time, right? And especially when I come back to Taiwan in 2003 to study so-called pain-associated tissue acidosis. In Taiwan, people always talk about I'm working on Seng. That's in our language. So my family member, when I tell them I'm working on pain, they automatically say I'm working on Seng, right? So this is a kind of very interesting concept in our society. Right. Then Dr. Lin, 2015, he came to me to pursue PhD. So I brought him a homework to ask patients whether their patient will complain about Seng. So that's the story start, right? So 1 or 2 months later, Dr. Lin came to me with the first record for his patient for the spine surgery, before and after surgery, right? And the story is very interesting because the patient is very painful with chronic low back pain. Before the surgery, she suffered pain with the higher, like the score at 10, the highest score, but without any complaint about the Seng. But interesting thing is after the surgery, pain reduced from 10 to 5. So the spine surgery was successful. But Seng come out from 0 to 5. So that's the first case, Dr. Lin's case. Tell us Seng exists in patient. So this something we come up together. We had to explain this. So that's how during that time, from 2015 to 2017 to 18, we had a lot of discussion with different clinicians in Taiwan. So we come out with a new hypothesis. If this should be, because in clinical it's very clear, it's a different symptom from patient's side. Seng and pain are totally different symptoms. Okay, and if there are two different symptoms, we should have a neurobiology. We should have a specific pathway for that, right?
Yeah.
So back to my collaboration with Guy and Bob. We know proprioceptor can sense acidosis, right? And proprioceptor, by definition, they are not pain-sensing neuron, right? Okay, so the story come out from here, and I think I'm not sure when is the exact time. Dr. Lin called me. He recalled one of his patients with a spine with a car accident, spine injured, right? And this particular patient totally lost pain sensation on his right leg, right? But this patient can still feel sun and still maintain functional proprioception. So this very specific case tell us sun and proprioception maybe follow the same neurocircuitry pathway. So let's go back to my collaboration with Guy. We further think about probably these are so-called this sun sensing neuron. It's come from the proprioceptor, right? So this is how we've done the further investigation on animal model and published the whole story in this year. So that's the.
That's great. So Bob, what's your input on all of this? What's your contribution?
Well, mine is really a joint one with Guy. We've been working together for many years now on aspects of how.
Yeah. Okay. Thanks for that, Bob. That was useful.
Okay, so,
yeah. Okay, Guy, you found us. Welcome.
Yeah, I'm glad I'm able to make it. Yeah, so to carry on.
Nice to have you.
To carry on Bob's story, as well as discovering this gain control mechanism. We knew that it was known that the gain control was there, but this was a mechanism by which it worked. As the endings release glutamate, activate this receptor on the nerve terminal that's releasing the glutamate, telling it how active it has been and remembering that and just keeping the system going at the right level. Well, also we wanted to know what is the stretch channel. So when you move the muscle, you must be opening something, you must be doing something in order for the nerve to detect it. Well, it wasn't known what the protein was that was detecting the movement. So we tried various different things, and one of the things that we found was highly expressed in these endings was these ASIC channels, the acid sensing ion channels. And that's where the work with Chih-Cheng overlaps, because he works on this acid sensation, acid detection, which is through these acid sensing ion channels, in particular ASIC 3. There's about 5 different types of channel, but we're looking at the third one. So the endings also have these acid sensing ion channels, but what we propose is that they're not there to primarily detect acid. They're there to respond to stretch, because there's other research showing that they will open when the cells that they're on are stretched. So we propose that these acid sensing ion channels are in the proprioceptors, the muscle spindles, are there to detect length change. But of course, that doesn't mean that they can't also detect acid. So if you inject acid into the muscle, which is the basis of Professor Chen's work, then one would presume that those acid sensing ion channels also respond to acid. And that's where the crossover comes. Now, when we were looking to see what type of glutamate receptor was in these endings, these stretch sensitive endings, we didn't know what the glutamate receptor was. We were looking for everything. So we screened for every known type of glutamate receptor. And depending on how you divide them up, there's either 11 or there's 25. So there's lots of different types of glutamate receptor. We went through and screened them all. And when we were looking, we found that there's a glutamate receptor that wasn't on the stretch endings, but was in little fine, very thin endings that actually go very close to the spindle. And they had a particular type of glutamate receptor, but it wasn't the one that was on the stretch sensitive ending. We kept on searching, we found a different one that was on the stretch ending. But we now have one, the stretch ending, which releases glutamate when it's stretched. 2, we have 2 different types of glutamate receptor, one on these little fine nerve endings, which are close to the spindle but are not part of the stretch response, or not detecting the stretch response, and one on the proprioceptor itself. So we have 2 different types of glutamate receptor. And both of those types of endings express acid sensing ion channels. So we now have very close together these 2 different types of nerve ending. Now, it turns out that very thin nerve endings inside are generally something to do with, or can be something to do with pain detection. So we have a little thin nerve, which might be something to do with pain reception, which has a glutamate receptor on it. And we have a stretch ending, where it's using the glutamate receptor to regulate pain control. Both of them seem to be able to detect acid. And the stretch ending releases glutamate. So we have a source of glutamate. And that's where we all came together. And this is where really Professor Chen has been leading the hypothesis as well. How do these things interact together? And that's led up to the experiments we did in the end.
It's quite awesome that there's collaboration of different ideas and different specialties to bring a theory together. And I think the discovery of a new receptor type is I guess what I was reading in the article, that now opens up a whole new pathway for pain medication, which obviously will be huge in terms of, because we all know pain is not pain. There's different types, there's different experiences of it, and there's so many patients who just show no response to traditional pain medication. And, maybe that's because that pain medication is targeting receptors that we don't even know about, that don't even, we don't even know exist as yet. So it's not all, it's a complicated thing is what I'm saying. And I guess you guys are helping to shed light on the neurobiology of it all so that the pharmacology can catch up and be a little bit more effective.
That's essentially the hypothesis, which seems to be getting more and more support, is that it's a different type of sensation. So I use this analogy, which isn't perfect, but it's certainly something that we in the West are commonly experience. There's a difference between an ache and a pain. So a pain is something where you don't want anyone to touch it. It's as Professor Chen has said in many of his articles, you protect an area which is painful. But an ache quite often will respond to a stroke and a massage. So they're both not a very nice experience. An ache is unpleasant and a pain is unpleasant. But one you don't want to touch, and the other you do. So it shows you that there are two different types of experience of this discomfort. So it shows that there are at least two different types of pain, if you like, one of which is protective and we will respond to classical painkillers, and the other one is this ache type of pain, which certainly me, as a Westerner, as it were, I regard that more of a song type of pain. That is, it's a discomfort which is not responding to painkillers, but is definitely there, and must be therefore going through a different neural pathway, because the painkillers work on a particular pathway. And if they're not responding to that pathway,
and in my
then it
mind,
must be a different pathway.
Movement and pain tissue lightens the ache. Busy people. Julie?
Jiann-Her?
Me?
Yeah.
I'm not the right person to, I'm not a pharmacologist. So we actually meet Dr. Chih-Cheng Chen. Some work for that.
Having said that, we still need to understand.
Not yet. Right now?
No.
I have a chronic pain at my right shoulder. I found, I make a diagnosis by myself. It's a muscle spasm.
Okay.
I cannot get rid of that. But that the painkiller didn't work at all. Only massage was strange. So I will always do this strange. Strange. Yeah, to do that. And for the for current status, as a from a clinical perspective, I think the sun can be as a phenotyping tool for help a clinician or patient to explain their phenotyping the patient, because as a clinician we know the pain, chronic pain is so complicated in patient. It is so heterogeneous. So sun is very good in Chinese, very good tool to phenotyping the patient. In response to echo with the I go to the Dr. Chen. Now I'm his student. He's my mentor. He always told me that he have to find some cool, current painkiller or current medication, which can, which one is better for kill sun. Okay, to relieve sun instead of pain. Yeah. I'm kind of looking for this by my clinical experience, and try to give some painkiller and some analgesic to I can use to the patient and see their response. Some work very well, but in some specific group of patients. Yeah. Okay. We're happy. Yeah. Good. Okay. Thank you. Bye bye.